let's mosey on back. We're in the home stretch here. Is the last page. This could be the most boring part. But I will do my best. This is paperwork, templates, documentation. But there's always a story, with every other one, every fourth one. Or maybe we could just do some interactive talking during it so we don't fall asleep. So please take a look at this paperwork. What this is meant to be is the practical implementation of what you've learned over the last 7 hours. If you were the first one, it's 4 hours, and during the 4 hours of this one. So we got several hours under our belt. And now how, if I were to implement it in my practice, number one, or to know what is expected in a traditional addiction medicine setting or practice that needs to be documented. This is kind of how we do it. It's not meant to be all of the documents you need to provide comprehensive treatment for those with addiction. Rather, it's meant to be a guide for you to form your own documents to evaluate and treat those with substance use disorder in the spirit of the new Medication Access and Training Expansion, the MATE Act, and the DEA and SAMHSA training requirement. How's that for a disclaimer? Covered it. Let's begin. So, demographic form, you're no stranger to demographic forms. I'm not going to belabor this one at all, other than to say, notice it's like referred by and emergency contact. Who are you with today? That's one of the big pieces with this. It's a big victory if you can get anybody to show up with them anywhere other than them by themselves, because the disease of addiction is quite isolated. Almost like, community and socialization is the opposite of addiction. Addiction in a lot of ways is isolation and me to myself. I burn the bridges, and my disease is telling me I want to be alone with the powder or the liquid that I've chosen. So they're pretty isolated by the time most of us come in contact with them. So, informed consent. This one is basically saying, I agree to participate in evaluation assessment to receive treatment and services, which may include medication management, clinical medical service, drug screen. We have to go through this because it's a little bit more invasive than our usual primary care checkup, right? So, I'm just going to go to the doctors, they're going to listen to my heart and lungs. But in this case, we're talking about, we want your urine, and we reserve the right to take your hair. We're just talking about hair follicle tests. We reserve the right to take a blood test. We reserve the right to check. We're asking for a little bit more. We're going to talk about some personal stuff. So the consent, informed consent, you want the person to have a good idea of what they're walking into when they sit down with you to do the debriefing. Is if you're trying to take a holistic look, you're trying to have support people present, you're going to ask them questions that are pretty personal, and you need their consent for all of that. The other thing is, it's my understanding, HIPAA and 42 CFR, that was never really meant for us to not communicate with each other, as in provider to provider. That was more for the elevator conversation. So we want to have that approval to talk to the other providers if we got to coordinate care. But when it comes to mental health and addiction, you need an extra layer, and that's what I'm going to point out as we toggle through these. This is a typical consent form that looks different than a consent form you would have in your office, because we're talking about specific releases here. When you're talking about the mental health and substance abuse kind of confidentiality requirements that are federal law regulations, there's 42 CFR Part 2, which is sort of a little more than HIPAA. We need to have the patient fill out, so patient name goes at the top, and then let's say I want to talk to their spouse. So the next line, I authorize the spouse's name to disclose information and obtain, disclose to and obtain from information. So the point of that is to get both ways of information. I want to be able to receive and to provide information to that person. And the relation to them needs to be specified And then you have to initial each one of those: mental health, eval, presence in treatment, progress in treatment, admission discharge notes. Every single one of those needs special attention. If one of them is not, it's not a checkbox, you got to initial it. So this is the way the training goes for having a properly filled out release of information that will comply with the federal regulations for confidentiality. They will be, each of those will be initialed if they are agreed upon. Some people come into the eval and they'll just give you that one. I got my support person here today. They can come in for the evaluation, but nothing more. I don't want any calls, return calls, nothing else. I will consent for me and my support person to walk in and talk to you. That's fine. And then you work on building trust, and hopefully you can get more of those boxes checked, or not checked, boxes initialed, so that you can communicate and do all that you need to with the support people. Notice there is the purpose of the is it continuity, is it emergency? They have to specify. So what is being said and the reason for it has to be specified. So this is a little more robust. Standard kind of health history form, not too much to point out here that you wouldn't already be familiar with. There are, in addiction medicine, kind of these sort of things here, which, we pay a little more attention to than other things, so they're a little bit more pertinent. We have, people coming in post-hospital, post-operatively and stuff like that. We want to know what medicines they're currently taking for allergies, developmental disabilities, so that would be how they learn. In group therapy and other types of therapy, you might need modalities that help them. If they have hearing or vision deficits, what's going on diet-wise, and also if they have chronic pain, of course. We're going to ask about chronic pain, as we were talking about in the last segment. This is a substance use history. One of the things I ask about, we ask about pretty much everything, but I don't put, it says, what drugs have you used intranasally or snorted or smoked? Notice there's not IV on there. I actually saved that on purpose for the sit-down, because some people have a lot of shame and guilt about indicating on a paper anywhere that they're using something intravenously. So I found that report, you could always put it on there. This is just the one I use and have developed. It's just I've gotten more traction when I actually sit down with them to ask them face-to-face about some of these more detailed things. If you're injecting, where are you injecting, how long has that been going? But when you have to develop your own comfort and style with asking questionnaires, for some questions can be taken as not very well and almost off-putting, and you don't want to start on that. For example, just in my I would dress professional, almost like I'm dressed today. I wouldn't necessarily wear a white coat. If that's you guys already know that or whatever, but that's another thing because of the sort of the fear that they have of being committed. They have a fear of authority sometimes, and they have a fear of some of the more clinical parts of medicine, so you don't do that. Nicotine is important. Is nicotine a drug? Yeah. Route of administration, is that important? Is it that nicotine is the most addictive substance on the planet as defined by, releases the most dopamine in the nucleus accumbens? And does it beat methamphetamine? No. But why is it so addictive then? The route of administration is the fastest possible, which is inhale, right? It passes the right heart entirely. We go lungs, left heart, right. Oh boy, that's fast. So it's the route and the fact that it's absorbed. Okay, so that's important because it does count. Alcohol, of course. Age of onset of first drink, that helps a little bit in the sense that I was telling you about. I'd like to know, it doesn't have to be. Some give me a very clear history. They were at a family picnic and they were 12 years old and they can remember who was sitting around, what music was playing, and that will tell you very clearly that it was like a warm blanket surrounded me. The first peppermint schnapps I had when I was 12 and nobody knew about it, I never forgot it. And from then on, I secretly did this, and it'll give you a good insight as to this disease was present probably, possibly from birth, and I just found something that helped me by happenstance. And then there's others where that's not the case. drinks. I don't remember when I had my first drink, somewhere around 15, 16 or whatever, with a couple of and then the disease kind of shows itself, later in life because of the reasons we talked about, that the disease is secondary. So, again, frequency and quantity, all that stuff is data driven, just to get a sense of what you're dealing with. In the route of administration, again, it gives you a snapshot into how far it's come. I don't immediately start injecting or snorting stuff. I chew it first, I swallow it first, I might take it in another way. And if I've already progressed into routes of administration that are beyond just taking a pill, then that'll give you some insight. This is kind of a grid that's frequently used by most folks in the field. They just call it the grid. Did you fill out the grid? Well, this is, not necessarily, this is all the stuff, most of the things so far is for the lobby. It's not necessarily for you back in the office, but they should have kind of filled this out before they see you in some form or fashion. Again, I found, often these grids include route of administration on there. In this case, in this one, I've chosen to leave it off, and again, it's more or less because of the shame and guilt piece about how they're using it, and just get that later, but you're getting enough meat on the bone to know what you're dealing with. It is very relevant that, the other side of this, as we're talking about dual diagnosis today, what mental health other conditions are there. Some of them very clearly, I have we're hospitalized for mood disturbance, anxiety, self-harm, things that were there before they used it. They were very clearly had mental health problems before they picked up a drink or a drug. And we want to know that. We want to know, was it pre-existing? And in those cases, in some ways they start using it might help the thing, but eventually it hurts it. So it ends up sort of not helping in the end, as in using. So what medicines, what treatment have you had? Did you do a mental health PhD? Did you have a psychiatric hospitalization? What have you been diagnosed with? And then what medicines, didn't work? We want to know what medicines didn't work so we can avoid that. It's the seizure on Wellbutrin we want to know about. Wellbutrin, just as an aside, can be an effective agent for some people, especially extended release, not the immediate release Wellbutrin. Very different. Immediate release Wellbutrin. Risky. It's XL, extended release. That molecule looks quite a lot like amphetamine. And one of the good things is long-acting. It might have a purpose, because it's dopamine and norepinephrine reuptake inhibitor. So we're trying to get long-acting dopamine in the central nervous system, not short-acting. So it could have a role. Could have a role for people with stimulant history. So here's the consent for testing. I agree to give you my urine, breath, saliva, blood, nails, hair, firstborn, whatever it is, I will be checked. So that's asking for quite a lot, but that's there. And you want to give folks the opportunity to understand what they're walking into. Again, this is before they even get back to sort of sitting with you, is that they understand this is just part of the workup. And this is a typical form, the way we would sort of fill in the point of care test. It's a qualitative urine drug screen, and it's a point of care test right in the office. You read it almost instantly within a minute or two. A lot of stuff shows up within a 48-hour window, 72 hours. You've got some stuff. Some benzos can linger 30 days, depending on the half-life of the benzodiazepine. Methadone can last a long time. So if you get a positive, you don't always know when the last ingestion was. A lot of the stuff is within 48 hours, 72 hours, but this is kind of the standard of care as urine drug testing as opposed to blood or hair. There are some saliva tests that are getting more reliable where you do a cheek swab, but they're not as inexpensive as this is at the moment. ETG, I want to point that out on there if you guys haven't heard of that one. Ethyl glucuronide and ethyl sulfite. Those are very useful markers for alcohol ingestion within the past 72 hours. Most accurate within the past 24. But you can see, it goes way beyond a breathalyzer. You take a breathalyzer, you got the last 4 hours you're looking at, something like, depends on, but this is going to look back more than a day. I haven't had a drink in 2 weeks, Doc, really? And then this is positive. Well, help me understand why it's showing you drank within the last 24 to 48 hours. Well, to tell you the truth, I have one every night. Okay, fine. At least we know what we're dealing with. Fentanyl, kratom dipsticks, if you can get them, those are also point-of-care tests. But I would definitely advise the ETG as an add-on. We have a 12-panel, a 13-panel cup. I have buprenorphine on mine, as you can see. I think that's very useful. And the cup is an ELISA-based test, and so you have to send out, especially on the first visit, you would send the first sample out for GCMS or LCMS, quantitative testing, and making sure that other compounds aren't in there. So this would be a standard kind of first visit, initial evaluation, lots of room to sort of the narrative. Everything is electronic health record now, so you can just sort of get that right in there. The chart, is, for lifetime drug use history, you got the grid filled out. But here's where we go for the IV use, prior detox, prior treatment. After you get through the history of presidential, and you're finding out why are you here. I mean, that's an interesting question. Why are you here? And the answers you get, if you're left with the answer, well, I thought I need this. You might let it pass for the day, but that's not why they're there. They're there because their spouse said, if you don't go to treatment, I'm leaving with the kids. That's why they're there. They're there because their employer said, if you don't get healthy, you're fired. They're there because they just got a DUI and don't want to tell you. So if you want, you can let it pass and say, yeah, they're here because they just want to stop, they just want to get healthy because it's time. I've just been thinking it's time. We already know the frontal lobe, it's hijacked. Their frontal lobe is hijacked, Past history, chronic pain, number one, along with mental health. And then, of course, we want to know, do they have, history of seizures? Do they have hypertension? The seizure part is particularly important when you're trying to assess if I'm going to take care of this outpatient. Am I going to go for the gusto here? Am I going to give this person a script and they're going to stay with me? Well, if they just seized out last week, no. But if they never had a seizure, that's important, right? If they're not using high amounts of benzos and alcohol combined with opioids, you might give it a go. But if you find out, they have a seizure history and they have had a history of DTs, the real DTs, that's another kind of a watch out, right? But if they don't have any of that, you can give it a go. Social history, very important. Family history, because we know the genetic risk factors. If you want to risk assess this and say, yeah, it was through the family, I got family history. But who are you here with today? That's a nice place to document. Who's here with you today and what's the relationship? Well, my spouse is here, but we're separated. But they said if I get healthy, they're going to support me and I can move back with the brace and go through treatment. Okay. And then another place to put, what they do for work. Legal history is DUIs and some other stuff. But, their occupation is important. And typically under the social family legal is a place to put, what they actually do for work. Back to that safety-sensitive question for employment. Current medications, what's the result of their test? It's sort of an abbreviated mental status exam and kind of a check to see if they're manic or psychotic. And then you go ahead and based on the following slide, this is going to be the diagnosis where you kind of bounce back, but you'll be able to rate their illness if they meet criteria for it. Remember, you need 2 or 3 criteria to have mild addictive illness. You need 4 or 5 for moderate, and you need 6 or more for severe addictive illness, and that's that mnemonic I had mentioned last time, the twist caps mnemonic. So in the meantime, while you're basically assessing them with their mental status exam, of course you're assessing them in the sense that, are they in withdrawal? So you got to do a CAL score, you got to do a CEWA score, and you got to do a physical exam. The physical exam paper is probably after, but this is where you're also kind of getting history too of what's their chance in dimension 1? Where is their withdrawal at? Are they at high risk after that seizure history? Are they mild, moderate, or severe? So an indication of 1 is low risk, an indication of 4 is very high risk. So you go through each of these 6 dimensions and you give them a risk rating. And once you come up with the risk rating, then you can basically recommend a level of care, whether that's outpatient, intensive outpatient, partial hospitalization, or residential level of care, based on which of these dimensions is severe. And this is part of the physical exam form, which happens right sort of as you're going through everything with them. You have to do your usual. Of course, the vital signs are taken when they have the urine drug screen, so they're already on there. But you're doing your basic physical exam also. And then you kind of put it all together in the final page. You say, look, I think they need detox. But I think we can do it outpatient. No, they need to go residential. I think they need IOP, intensive outpatient. And then you kind of put why, and you might put for how long. You might, if you give them prescriptions, put that there. And then kind of talk about the bullet points about these are the risks. I've talked to you about these medications, and then when you use a specific medication, you'll see another slide, we talk about what the risks are for the specific medicines. You have to do labs on them, baseline, look at their liver and kidney. They need a primary to ride along with you. They might need other people, depending on their co-occurring. They might need a pain management doctor to ride along and do some procedures while they're in treatment with you. They might need a psychiatrist if you're only doing the addiction part, and they're going to do the psychiatry. You need to have a partner in that. And the fact that you reviewed with them the risks of abruptly stopping drugs or alcohol. And it's a catch-22. If they keep drinking and using, they're at risk for overdose and serious health consequences. If they stop, they're also at risk of having serious health consequences. So it's like sign this that says you're in bad shape, You don't have many options. If you keep going, it's bad. If you stop, it's bad. So that's why they need help, to get out of that cycle. So here's a standard consents for treatment with the buprenorphine and naloxone, naltrexone. So this is what a standard contract, when you go ahead and use buprenorphine, you have them understand a few things. This agreement was mostly formed not necessarily for pain management, but for opioid use disorder. So you won't be able to. You have to adapt quite a bit for the pain management part. But I understand I've been diagnosed with this condition, and I've elected to enter this outpatient treatment program. And I understand what buprenorphine is. I understand that not everybody's appropriate. I will take my medicine as prescribed. I understand that the dog ate my homework will not be a reason to refill early. I understand that I need to do some, if I don't show up, then it could be a violation and points to my need for more help. This outpatient thing might not be all I need. It's not punishment, like, oh, I can't make my appointment so I'm bad, or you're going to fire me. It's like, no, the data is pointing to you need more than I can give you. So the reality of this agreement is like, if it's not working, it's that you're sicker than you thought. I will abstain from medicines or substances not prescribed to me. I will dispose of paraphernalia. That's triggering, right? I just want to hold on to my favorite wine glass. I want to hold on to my favorite syringe. And I just go get syringes and look at them. I don't need to use them. I just want to hold them. They make me feel. Of course they make me feel. That's also been shown too, that certain paraphernalia can mimic the use of the drug within 70% of the spike of the dopamine if they actually used it. So, that's been looked at, and we want to avoid spiking drops in the nucleus accumbens and the dopamine. So, we want to get rid of it. That whole thing comes through in early recovery, where it's like, I want to do my same routine, have the same friends, the same routine. It makes it hard, because the hippocampus and the memory center says, remember this, remember that. And really, if they're giving it a good try, they have to change everything. They got to let a lot of stuff go and take a break from stuff that remind them of the old ways. It's not easy. I understand that you got to be able to reach me. Give me a couple of phone numbers. Here's the list of somebody else you can call. I'm the only prescriber. If you need to have emergency care, definitely go do that. Okay, I understand that I have a release for this other provider. Oh, I understand that counseling, therapy, and outside sober support, 12-step facilitation, or other community support are recommended in addition to my medical therapy. So yeah, I want to complement my medication use of buprenorphine use if you're going to do this in your clinic with meetings, therapy, other modalities. And I understand that the following parameters outlined here may indicate my need. If I can't follow the following parameters, that may indicate my need for a higher level of care and to treat my medical condition. And I'll be open to hear such recommendations. So it's worth, to some extent, if you're going to go this far, you're going to go this route, you almost take a document like this and you kind of go through it with them. So there's no surprises. And you say, look, if things go sideways, it's just going to be proof that things are stronger than you thought. That's all. And I'm going to come with recommendations, and we're going to do this additional stuff. This is when you do prescribe the buprenorphine. This is a sample of an explanation to the patient and family of how to use it. You're going to have an assessment. You're going to have an induction where you have to stop everything. You're going to be in withdrawal. Why do I need to be in withdrawal? And so this is an explanatory form so that they can read it and understand the process. Again, something you might need to go through. And that's why the question came earlier, how long do you spend with a new patient and family? Well, sometimes 2 hours. Sometimes the first visit is 2 hours. It can be done within an hour. This is just their copy of the same document. Frequently asked questions. Why do I have to feel sick to start the medication? How does Suboxone or buprenorphine, I should say, work? When will I start to feel better? How long will it last? Can I go to work right after my first dose? It's important to take my medication at the same time every day. If I have more than one tablet, I need to take them together at the same time. So all of these are fair game. People can be dosed at one time a day. Sometimes it is better to dose twice a day. I've found that starting most people with a morning dose, say 7 or 8 in the morning, and 3 or 4 in the afternoon is a good way to go. You just split dose. If you know it's 8 milligrams, just do half and half. It seems to be a good way to start. Other questions, why does Suboxone need to be under the tongue? And that's because that's where it's absorbed. If I swallow it straight down and don't let it absorb sublingually, I won't get the effect of the medication. In fact, I may absorb the naloxone and get a little bit more detectable naloxone in my urine than buprenorphine. So I don't need to swallow the pill down, I need to let it dissolve completely underneath my tongue, and it's all absorbed sublingually. After the 2 to 5 minutes, depending, usually if it's filled, it's 2 minutes. If it's a tablet, it might take 3, 4, 5 minutes. They can spit their saliva out. They don't need to even swallow their saliva because the absorption is so little. If I forget to take my Suboxone, well, that gets back to the half-life. Sometimes, the half-life is long enough. If they didn't miss a dose, they probably won't be able to tell. But if they miss 2 doses, I would bet they would feel it. Pregnancy. Should pregnant women take buprenorphine if they have opioid use disorder? It's kind of replacing methadone. It's kind of replacing methadone as the standard. Methadone was the standard for years for opioid use disorder in pregnancy. Methadone was it. Now it's filling buprenorphine. So I wanted to have a consent for that. And that's just where the literature is heading, the field's heading, and it seems, and there might be some neonatologists in here, that the effects, neonatal abstinence syndrome, the opioid withdrawal complications for the infant seem to be less. Is that true, Doc? So it seems to be less with buprenorphine. So that's where it's heading. This is for naltrexone. Now, naltrexone comes in. Now, I want to make a distinction. This is not Narcan nasal spray or naloxone nasal spray. That's rescue medicine. This is naltrexone, 50 milligram pills. One brand name is Revia. There's naltrexone extended release injection. It's an intramuscular injection once a month. So this is for basically Oral naltrexone every 4-week injection, every 28 days. So it's quite useful, to tell you the truth. Lo and behold, it was studied for opioid, mu receptor antagonist, right? And it seemed to cut some cravings for the opioid use disorder. And then lo and behold, it seemed to affect the pathway that's reinforcing for alcohol too. So it doesn't allow that dopamine release in the nucleus accumbens to that degree. So it seems to be effective for alcohol use disorder also. You can't take any opioids in the last 7 to 10 days before you take a naltrexone injection. That would be bad. You shouldn't mix things with it either. Injection site. The most common reactions to this is soreness at the injection site. Some people get a headache and some people get nausea. Often before you do an injection with extended release naltrexone, you should test them, test dose on the pill. You should give them naltrexone pills, 50 milligrams, break them in half, 25 milligrams, see how they react. Take it with food, take it in the morning with food. The other side effect can be a little bit of somnolence. So they might need to dose it at night. So GI, little nausea, somnolence, headache, those are the top 3. But if they tolerate the pill well, they'll probably do well with the injectable naltrexone. And it seems to be, clinically, and I can speak to this, and more effective. It's like, it takes more edge off the craving, particularly for alcohol. It's used for opioids and alcohol, but most often for alcohol because of the nature. Let's say you miss an injection, you're on it for opioids. The receptors are primed again, and you go back and use the same amount of opioids you used to use before and die because the receptors are sort of restored and you kind of use the same amount. You had the time to lose your tolerance. And then so there's a lot of chance of the bad things happening if you miss. So there's a risk there. But it still is used for that. It's just certainly more comfortable for the practicing clinician with alcohol use disorder. There is some effects on the liver, but you gotta, if they have a 3 times upper limit of normal, LFTs or something like that, you're probably gonna hold it. But other than that, acamprosate is a good one to use if they got liver problems. Then, you gotta wear. You typically give a card or a bracelet, almost like a MediAlert, so that if they come to the ER and they're on injectable naltrexone in the last 28 days, and you're trying to give them analgesia, and you're wondering why I can't override this, if most people who give the injectable naltrexone give them a card to put in their wallet or a bracelet to wear, saying I'm on naltrexone. This would be like a follow-up note, just to get a sense. If you were giving naltrexone, after you have established it down and you're giving naltrexone, something that's kind of efficient as a procedure note, it's typically given in the upper outer quadrant of the glute. So you rotate sites, one time on the right, one time on the left, upper outer quadrant of the glute, and checking how they're doing. Another type of a follow-up note, if you're not doing injectable naltrexone, could look like this, to see how they're doing after you started them on buprenorphine or another agent. You're still classifying their illness at the end, but you want to know how's mood, how's sleep. Of course, the obvious, big ones, suicidal or anything turning very dark. You want to know about cravings. You want to know about cravings. And then the end plan is like, well, let's keep going at the outpatient or the IOP level. You need residential, and you sort of want to cover those bases at the bottom. This is a send out, for what it would look like typically for after you do your qualitative in-office point-of-care test. So you do your 12-panel urine drug screen in the office and you send it out. This is what you're going to get back. This is a LCMS, liquid chromatography mass spec. They have GCMS, some vendors. In this particular one, it's LCMS in them. The person had some fentanyl analogs, as you notice from the results. We had buprenorphine, so they were taking their buprenorphine, and you can see, remember I was mentioning the ratio flipped that bupe to Norbupe. So you got more Norbupe than you got bupe. So they probably were taking their buprenorphine as directed, but they came over the top and they used fentanyl on top of it. And so, we had the parent compound and we had a metabolite, but then we had the analogs also there. So whoever they got the stuff had many of the things in it. In this particular one, I was trying to see about the xylazine. We did look for that on this one, and I think it came back negative. But again, back in the 1 and 4, at least, are going to have xylazine in it too. But this is what a thorough. We were asking or talking before about what are you really looking at. It's going to look something like this when you test the sample. So remember, buprenorphine maintenance duration of treatment is as long as it takes, and the majority of patients respond somewhere between 4 milligrams and 24 milligrams per day. There's no maximum or minimum duration of treatment. Severity of addictive illness and variability between patients requires individualized dosing and monitoring parameters. Often the split buprenorphine dosing, morning and late afternoon, for optimal clinical benefits is the best way to go. Goals include stability in most areas of life, which means improved relationships and sober support, improved family living situation, improved or stable mental health, decreased stressors, and regular daily activity, whatever that means to that patient. Employment, student status, caregiver, volunteer activities, whatever it is, that's how you can tell if you're on the right track and getting better. Because when they were sick, they didn't care about those things. So, medication-assisted treatment appears to be most effective when combined with multiple modalities, including psychosocial treatments at the level of care that's needed, indicated by the ASAM dimensional assessment, mutual support groups, 12-step facilitation, group therapy, individual therapy, counseling, and other non-pharmacologic approaches, as well as treatment of comorbid psychiatric conditions, are important in the comprehensive treatment plan. And there's the bold. Buprenorphine is an important option for patients with co-occurring chronic pain syndromes and substance use disorder. And now that the Consolidated Act is passed and the X waiver is waived, you will be able to use that as a tool in treating chronic pain and opioid use disorder concurrently. Addiction is a chronic disease, and as is with every disease, the severity of the condition must be assessed and appropriate treatment recommended, and follow-up. Without follow-up, relapse is likely. Don't let anybody tell you relapse is a part of recovery. It makes no sense. Relapse is a part of the disease. I'm sick, I relapse. Relapse is disease. Relapse is not recovery. Or it's not part of recovery. But you know what? You make lemonade out of it. I've had folks go through treatment and they relapse and they feel that all hope is lost. And it's just an opportunity. It's an opportunity to dig deeper and for them to appreciate the power of their illness and do more work. And they actually make a turning point. They actually get better from there. So relapse, just for the nomenclature, so you hear certain things and you're like, is it? That seems like a catchy phrase. But it's like, no, that's an opportunity to go a little deeper, work a little harder, and be part of building a base and building a recovery. But in and of itself, it's a marker that I need to do more work and look a little deeper. The ASAM criteria and dimensional assessment provide the overall picture and data to recommend the level of care needed for the patient with or without medication-assisted treatment, and that correlates with the highest likelihood of treatment success or remission status. Multidisciplinary team with multiple modalities, including MAT and individual and group therapy, as well as outside sober support, is often the key for successful treatment of moderate to severe addictive disease. The final slide here is, if you're really interested, they have the Providers Clinical Support System, PCSS. It's a national training and clinical mentoring program that's funded through SAMHSA, the Substance Abuse and Mental Health Service Administration. It's free, and it provides clinical mentors and matches them with clinicians. There's 3 levels of involvement, depending on how deep you want to go. Very few actually know about this, but this would be like a support, somebody you can call, somebody who you can they have, once a month or once a week conferences, and you could just listen in. But then it goes further, to where you could be involved at the highest level, where you have like regular phone contact with a mentor in addiction medicine, who would kind of guide you through the setup if you wanted to like have that as part of your practice. You would actually get paired with somebody who you could kind of, ask questions, and they'd help you set up that part of your practice. And then if you need to reach me for any reason, I have an email there. But what a resource that is that's already kind of paid for. I appreciate your attention. That's it for today.